I'm going to do today is just kind of give you an overview. I want to educate a little bit. I'll show you my objectives. Okay, so we're going to just kind of go over the basics of the physiology of blood and bone marrow, which is the organ that produces the blood. So we're going to just delve into a little bit of the basics about that and help you understand a foundation for all things related to leukemia. And then we're going to teach you just a little bit about when you're looking at a CBC, which we talk about so much, and what are we actually looking at. So I want to teach you a little bit about that. And then we're going to discuss what happens when a patient does develop low blood counts. So anemia or low platelets, which we call thrombocytopenia, or low white count, which we call leukemia. So we'll go through a little bit of that. And then we're really going to make it kind of brief, but I'm going to talk to you about the different types of leukemia. And then we'll talk even more brief, just kind of a quick snapshot, sort of the lay of the land, some of the treatment approaches for leukemias and by type. And then but I'm really going to touch on just some of the newer concepts and newer treatments that are available.
There you go. Beautiful.
All right, so this is like a cartoon of what bone marrow looks like. So if you were to do a bone marrow biopsy and see those different cells in different proportions, and they grow, right? So everything starts out, see my pointer, kind of starts out as a stem cell, and that stem cell can differentiate into a myeloid, a lymphoid progenitor, and then these myeloid progenitors can grow up into the line that can produce platelets, or can produce red blood cells, or white blood cells. So these stem cells are really important. And when things go wrong in these stem cells, you can end up with a variety of different problems. Same thing in the other side, the progenitors can do the same thing. But the end result of all this development or differentiation of these white blood cells, all of these blood cells, is mature blood cells. So the primary mature blood cells in your body, when you look at your blood, there's the white blood cells, there's the red blood cells, which contain the hemoglobin, and there's the platelets. So the white blood cells' jobs are to help you fight off infections. The hemoglobin and the red blood cells' jobs to deliver oxygen to the tissues, and the platelets, their job is to stop bleeding or prevent you from bleeding. There's a lot of different subtypes. When you look under the microscope, that's what you see. So every time we do a CBC, we basically have a really expensive machine in our lab, our cancer center, and it takes a picture. It takes the blood smear and it literally puts a drop of blood onto the slide, and it just smears across. And our machines are very fancy, so they actually will, do this in a test tube, and they can give you measurements. They can count the numbers of cells, and ultimately it makes a slide that we can review. And so, for example, these red cells, which are kind of pinkish, you can see those are red blood cells. These larger, you can see the point of these larger cells with these multinucleated cells. This is our multi-lobe nuclei. These are infection fighting cells called neutrophils. And here would be like a lymphocyte. And these teensy tiny little purple particles here, these little tiny flocks of purple, those would be platelets. So you can see what the different cells look like and what we're talking about when we talk about a CBC. So white blood cells, red blood cells, and platelets. So when you get a CBC report that you might take a look at, you will see the total number of white blood cells. That's all the white blood cell count. And normal runs anywhere from about 4 to 10. And if you have, in the medical terminology that we use, if it's low, we call this cytopenia. So penia being not enough. And if it's too much, we'll call it cytosis. So osis means too much, penia means not enough. So just to kind of give you a little bit basic medical terminology. And so that's the white blood cells. Now, every time you're going to do a white blood cell count check, your next question should be, well, which kind, right? So that we call the differential. So is it a high neutrophil count? Is it a high lymphocyte count? Is it a high eosinophil count, basophil count, monocyte count? These are all the different types of white blood cells that you'll see in the peripheral blood. So if it's high or low, you want to know which type is high or low. That's very important. If it's that how actually could help us figure out what kind of leukemia somebody might have. If the lymphocytes are high or, eosinophils are high, it really gives you a good idea about what you're dealing with right off the bat. So the hemoglobin, that's the inside the red blood cells, but we don't really often need to count. Well, we get a number on that report of red blood cells, but it's really not that helpful. The way that we really talk about red blood cells is the hemoglobin. The hemoglobin represents the oxygen carrying capacity of red blood. So we can be focused more on hemoglobin rather than the number of red blood cells. You don't need to worry about the number of red blood cells. It's the hemoglobin that matters. And hemoglobin is a measurement of grams per unit, whereas hematocrit is a percentage of comparative fluid in the tube. So it's really, we use hemoglobin for most cases to measure oxygen carrying capacity. And so if someone has low hemoglobin, we call it anemic. Okay, and if their hemoglobin is too high, we call it polycythemia, too much blood. So we have big doctor words for these things, but that's what we're talking about. There's a measurement on that CBC called the MCV, and MCV is the mean muscular volume. It just tells us if the red cells are big or small, normal size for that matter. And the machine measures it for us, but it's a useful tool because if you're looking at somebody's blood and they have enlarged red blood cells, you'll think of one thing, for example, like multiple myelodysplastic syndrome, vitamin B12 deficiency, a number of different things you can think. But if their red blood cells are small, you may think of things like iron deficiency. So it really helps us to categorize the anemia. There's some other measurements which are not all that important for the purpose of this talk, so we'll skip over them. And then we have the platelet count. So the platelet counts are very important because platelets, as I mentioned, help you to not bleed or to stop bleeding. Platelets are unique in their almost between 150 and 400,000. And we'll talk a little bit more about what happens when the platelets are low. Basically, there's risk of bleeding, and we'll talk about some different levels in which you need to be concerned about that kind of thing. All right, and then I mentioned the peripheral blood smear. I showed you the blood smear, and by looking at the cells themselves, you can learn a lot. The pathologist will do this, and the technical lab will do it, and they'll help describe what they're seeing, and that informs us about what's happening with that patient's blood. All right, so first I was going to talk about red blood cells. So this is like a dry micrograph. They take it really detailed, fancy picture. They don't look like that unless you have very fancy equipment to take pictures. But so I mentioned that if you have anemia, that means not enough red blood cells. So normally your hemoglobin for a man would be like 13.1 in our lab up to 17.5 or 18, and roughly, and then in a female maybe like 11.9. So females tend to run a little bit lower. That's just normal, and this is how we're all built. So what happens if you're anemic? What kind of symptoms would you have? So it depends really if you get anemic because you just bled half your blood volume, in which case you get shocked lying on the floor and you'd be in the intensive care unit, or if you became iron deficient and then sort of gradually ran out of iron, which then kind of gradually made you run out of blood. So there's a real nice distinction between acute anemia, which patients can tolerate very poorly and they'll be really sick and in an ICU, your blood pressure will be low, you get shocked. Versus chronic anemia, when it happens slowly over time, you could have a hemoglobin of 5 and feel, if you're otherwise healthy, might feel a bit tired, but some patients will feel fine, hemoglobin of 5 or 6. So it really depends if it happens suddenly or if it's more gradually, so your body can compensate in different ways. Now, if your hemoglobin is low, assuming it's not acute, if it's chronic, then your body has time to get used to it. You might feel short of breath, you might feel fatigued, could be pale, and could have palpitations. Some patients have headaches, and just run down, like not a lot of exercise capacity. And when it happens slowly and gradually, sometimes patients don't realize how bad they feel until we identify the problem for them, and then we treat their anemia, and suddenly they're feeling significantly better. So there can be this compensation, and the body kind of gets used to it. But anyway, when did we call anemia severe? Anemia is an important concept. So mild anemia is, something like hemoglobin around 10 or greater. Once it gets down to around 8, you start thinking, okay, this patient might start to be symptomatic. Most patients aren't going to be symptomatic in hemoglobin over 10. That's a mild anemia. If your hemoglobin's coming around 8, you might start to feel more tired or symptomatic, and certainly less than 7. We know less than 7 puts an extra strain on your heart and lungs. And then we start really thinking about, does this patient need a transfusion to boost up the hemoglobin so it doesn't strain their body? Obviously, transfusion is only a temporary solution. We actually want to fix the problem. We want to diagnose it, understand why they're anemic, and then we want to fix the problem. So a transfusion of blood is temporary. So when I talk to patients about blood, I talk about how long does a red blood cell last, right? So a red blood cell normally will live about 120 days and it dies. That's its sort of natural life. So, for example, when we give chemotherapy, patients can become anemic from chemotherapy, but that tends to be more gradual because again, red cells live longer. So the platelets and the white blood cells tend to have much more fluctuation when we do treat with medicines that can affect the bone marrow. So let's go on and talk about the white blood cells. So I mentioned that we have neutrophils, eosinophils, basophils, lymphocytes, and monocytes. The most important white blood cell, I think, is called the neutrophil. And you'll hear us talk about this neutrophil, which is I call it the soldier, or the front lines, infection fighting, first line of defense against bacterial and other infections, but particularly bacterial infections. And when we talk about neutrophils, we talk about the absolute neutrophil count. Or in other words, when you look at that blood report, it's the neutrophil number, the pound sign, okay? We don't really want to look at the percent because that just depends on the total white count, so that can be very misleading. So we don't like to look at the percentages. We looked at the bottom of that report, the absolute number, and that gives us a good estimation of the absolute neutrophil count. So what do we worry about? So normal is over about 1,000, maybe 11 or 1,200. But when the neutrophil count goes under 1,000, then we start to a little bit worry about the risk of infections, but really less than 500 is when we get concerned, because when the neutrophil count is less than 500, then we start to be concerned about bacterial infections, including the bacteria that live inside your body, which can try to creep into the bloodstream, make you very sick. So when the neutrophil count is under 500 or 0.5, you might see it noted as in some places. Then if you get a fever, we consider it an emergency. The patient has to go to the hospital and get an IV antibiotics to protect them, because it could be the bacteria that only lives happily in your body, in your colon, and in your mouth, on your skin, that's trying to creep into your body, make you sick. So that whenever you're talking about low blood counts, we want to be aware of the absolute neutrophil count under 500, which is if you get an infection or fever at that time, that's considered an emergency situation. You have to go to the ER and you got to get that taken care of. So there's not too many diseases that we're not going to spend any time talking about the rest of these. There's one kind of myelomonocytic leukemia, but that's something for another day. It's relatively rare. There are lymphocytic leukemias, which we're going to talk about a little bit today. There is really very rare to see any sort of basophilic leukemia, almost unheard of. And then there are chronic eosinophilic leukemias, but again, those are very, very rare. So if I were to quiz somebody, probably, but if we had.
He's a teacher, folks.
Red cell count, we would call leukocytosis. Okay, remember, cytosis is too much, and if we had a low white blood cell count, we would call it leukopenia. Meaning not enough. So now we've applied that concepts. All right, so then these little guys here, so the nice red corpuscles you see, but then the smaller little chunks here, those are the platelets, and they help stop bleeding, prevent bleeding. So normal platelet count runs between 150 and 400,000. You could have many platelets, thrombocytosis, or too few platelets, thrombocytopenia, right? And when do we worry? So if the platelets are a little bit low, as long as they're over 100,000 or 150 is lower limit of normal. If they're under 100, if they're right around 100,000, that's all good. I mean, nothing bad happens at a platelet count of 100,000. You could have brain surgery and, nothing's gonna happen to you. But once you get under 50,000, that's when the risk of bleeding starts to go up. So we get a little bit worried. So under 50, we tell you, no, you should probably take aspirin or use non-steroidal anti-inflammatory drugs or other medications, blood thinners that can cause bleeding. So under 50 is where we start to worry. Over 50, you can have abdominal. Over 100,000, you can have any surgery. Under 100,000, the neurosurgeons don't like to do spine and brain procedures because bleeding in those places is not a good thing. But you can still have abdominal surgery or chest surgery as long as the platelet count's over 50. Orthopedic surgeries would be okay too. So under 50,000, the risk of bleeding goes up. We get concerned. But really under 20,000 is when we really start to worry. And then that's where we start thinking, well, maybe we need to think about giving platelet transfusion to prevent bleeding. And under 10,000, there's an increased risk of spontaneous hemorrhage, including in the brain. So when we get under 10,000, we really need to give platelet transfusion to prevent spontaneous bleeding. And the problem with platelet transfusions is a normal platelet lives 7 days. That's its half-life, and that's how long it lives in the body. And the platelets that we have in our blood bank are donated. They've been sitting on a shelf for a while, so they just last a few days and then they wear off. And then you got to get them again. So it's really just a patch. We really need to find the underlying cause and fix it. Otherwise, you're going to be in the lab. You're going to be in your doctor's office every 3 days getting more platelet transfusions, and that's very inefficient. So if you do get a platelet transfusion, it has to be repeated until your body can make its own platelets, right? Otherwise, it'll just go down again. So hopefully, while sometimes, for example, with chemotherapy, we'll give it and it'll stop the blood production for a while. Platelet count will go down. If it goes too low, we give some transfusions, and then it'll go up high enough, and then you don't need transfusion anymore. So that's the concept. So we already talked a little bit about the symptoms of anemia and whether it's acute or chronic, right? If you bleed out half your blood, you're going to be having shock, be low blood pressure, you'll be in the hospital for sure, or you could die of that even. If it's chronic, you could have the same hemoglobin, but you may have very few symptoms or just have mild symptoms. We talked about the risk of infections with neutropenia. Remember, that's low absolute neutrophil count, less than 500. That could be an emergency if you ever have that fever with a low neutrophil count. It's an emergency. And then we talked about the risk of bleeding that can occur when the platelets are less than 20, but really less than 10. And otherwise, platelets over 50 or over 100,000 patients usually do just fine. All right, so now digging in a little bit to the approach to leukemia. So what is leukemia? It's cancer of the blood or of the bone marrow. Now, it comes in different flavors, right? There's a lot of different kinds, and I've really simplified it, but I have some pictures here of a myeloblast in acute myeloid leukemia. You can see on this panel, and you can see these little purple rods there. There's little owl rods. So if you ever were to see a patient with acute myeloid leukemia, if you looked at them, they had these really big blast cells or owl rods. That's a myeloid leukemia cell. And the other acute leukemia that we see is not myeloid, but lymphoid. So this is ALL. It's much less common in adults. This is the most common leukemia that you see in kids, but we don't see it all that often in adults, although it can occur. And then we have chronic myelogenous leukemia and chronic lymphocytic leukemia on these lower panels. So these are all treated in different ways. Some of them have better prognosis, some of them have a worse prognosis. Some we consider curable, some we consider treatable. And you got to work with your doctor to understand what is the expectation from a diagnosis of one of these things. And so the expected prognosis is important. Can it be cured? In hematology malignancies, oftentimes, or at least sometimes, we have to consider, is the stem cell transplant, part of the treatment? And the other consideration, first of all, is it something that might be needed? Secondly, is the patient healthy enough to even do that? Because a lot of these diseases are diseases of older people. So, if you're 80, you're probably not going to get a stem cell transplant, even if it would cure you, the disease, it would be not safe to do so. So we have to think about all these different ideas. All right, so the reason that hematology is as a field is so exciting is because it really was the first oncologists. Hematologists were the first oncologists. There was no chemotherapy. Oncologists gave chemotherapies to prevent or to treat cancer. The medicines that go in the IV or pills nowadays that treat cancer, we call chemotherapy. And prior to the 1970s or 60s, there wasn't any. I mean, literally the first people that graduated from oncology fellowships in the Chicagoland area were in the 70s, and they were hematologists. That's really chemotherapy really came to be a thing. But they discovered chemotherapy, as many things are discovered because of war, unfortunately. And in World War I, they discovered nitrogen mustard, and it was used as a chemical agent, and it induced bone marrow ablation. So they would gas the troops, and they'd all die of bone marrow failure. So what they found is if you could contain this power and give it in a more measured sort of a way, you could actually shrink tumors. And the problem is that tumors would grow back. It didn't cure patients, but they found out when you give it again, it would shrink the tumor again. And actually it was effective therapy for some leukemias in those early days. So we used nitrogen mustard in oncology up until about 15, 20 years ago. For example, for Hodgkin's lymphoma, we used nitrogen mustard. So we don't use it anymore. We have safer, better, more ideal chemotherapies with better side effects and risk profile now. So chemotherapy proliferated, and they developed all kinds of new drugs from the 1970s onward, and they developed combinations of chemotherapies, and it was able to effectively treat and cure some diseases, including some leukemias, some lymphomas, testicular cancer, for example, can be cured with chemotherapy alone. And the problem is that in many solid tumors, and even in liquid tumors and leukemias, the problem is that resistance can develop, and then it grows back, and then they're kind of back to where it started from. And that's why we can't cure it all in cases, even though in blood cancers, the treatments usually work. But the problem is that you can get into remission, but can you stay in remission, right? I.e. cure, that's always the trick. So, well, the years that I was in my residency were some of the most exciting years. So we're talking about the early 2000s in hematology, because it was an era where we went from chemotherapy, which has a lot of side effects, and I just described it's not always so effective. Well, it can be, but not always, right? To an era of targeted therapy. So we had better understanding of what was making these leukemia cells tick. So, for example, there was this disease we mentioned, that chronic myelogenous leukemia, and it was characterized by this chromosome transformation of the 922 chromosome called the Philadelphia chromosome. So you do a bone marrow, the patient comes in, they have a very high white blood cell count, they might have high platelets, they may be anemic, and you look at the blood smear, it looks like their bone marrow. It's for a variety of immature cells. The blood smear looks like the bone marrow. That's the hallmark of the CML, and you do all the testing and you find the Philadelphia chromosome. Well, prior to the invention of this drug called Gleevec, the treatment for that was to have a bone marrow transplant, which has a lot of risks. You can die from the transplant, you can die from infection after the transplant, you can get sick or die from graft versus host disease when the bone marrow transplanted into your body. Can attack leukemia and cure you, but can also attack your body. That's called graft versus host disease, so that's no good. So some very smart people figured out how to create a molecule that really fit into the pocket of this enzyme, which then somehow miraculously really can reverse this translocation of the DNA. And they did the initial trials, and it worked in almost every patient that they tried it on. And then within a few months, they said, "Wow, this is pretty amazing," and it was approved by the FDA, and it revolutionized the world of leukemia. Chronic myelogenous leukemia is no longer a fatal disease. In most cases, it used to refer to acute leukemia. A patient would die in a few years without a stem cell transplant. Now, patients routinely take these pills, and they're usually fine. There's some exceptions, but in general, the prognosis is very excellent. So that was pretty exciting, and this is the proof of concept of the now in the era of targeted therapy rather than the era of chemotherapy. And so it doesn't, you can't do targeted therapy unless you know what target is, right? You have to know what's driving the leukemia cells. So if you don't know what target is, you can't design a treatment to turn it off. So the thing about CML is it's really just one gene. Well, that's probably oversimplification, but they found the right one. They found the right gene to turn off so that they could then put the disease into long-term remission. It's not so simple for other cancers where there may be a lot of genes and some are upregulated, some are downregulated, and some are important and some are not important. But the good thing is we actually have the technology to measure these genes now, and we didn't before. So right, if you can't measure it, you can't treat it. If you can't see it, you can't design a target for it. So the science has come a long way, especially with the help of all this. Before we came in here, we were having a conversation about computers, right? Before the computer and supercomputing and big data and all of our ability to collect and analyze, our ability to sequence rapidly tumor DNA, these have changed everything in the science of oncology. So we're going to get better treatments. We're going to get better targeted treatments. All right, so that's what I was going to tell you about CML. Pretty exciting. And most patients are doing very well now. AML is a different story. So this is acute myelogenous leukemia. And one of the common themes with all oncology, especially the blood cancers, is prognostication. So what is the expected outcome? So the problem is that you can look under the microscope and you can't predict the outcome, right? Because they all look the same, but let's say the cure rate's 50%. How can you look at the microscope and say, okay, that guy looks like he's going to be cured, and that person doesn't look like it? So science, that's how we do it. So what I have up here is a clip that I took out of the National Comprehensive Cancer Center Network guidelines, and it just does a very good job of categorizing patients with acute myeloid leukemia into risk categories. So pathologists will take the bone marrow and they'll run all these tests to check for these different proteins. And if you fall into the favorable category, you might have a cure rate of 70, 80%. If you fall into this risk category intermediate, it may have a cure rates of 40 or 30 or 50%, in between. And if you fall into the adverse poor category, then the cure rates are pretty abysmal, to be honest. And that helps the doctors drive a decision in this particular case about whether or not a bone marrow transplant would be appropriate. Okay, so I wanted to help understand this concept of prognostication. So what is the expected outcome going to be? But also recognize there's different factors. So every AML is not the same. All right, so then I mentioned about the targeted therapies in CML, Leukemia, but the same is true for all these other leukemias. So we've been using 7+3 chemotherapy as therapy to doxorubicin since I was born in the 1970s. But it's very toxic. Patients stay in the hospital for a month usually. It's caused a lot of risk of infections. There's some risk of death, even it's very, very dangerous stuff, especially in older people. Younger people tolerate better, but in older people, morbidity mortality is very high. So even in older people, we hesitate to even use it unless we think we can cure them, like the good prognosis AMLs. But for the older patients, where we may really say maybe it's not worth the risk. So then they've discovered other things as they've gone along, including some targeted therapies and some antibody-based therapies. But then later on in 2017, 18, and the 20s, we see that they've identified targets which we can design drugs which could be effective. So we have this drug here called anacetinib, which can target the IDH2 receptor, the IDH2 protein if it's on the surface of leukemia cells. And it's only about maybe 20 or 30% of leukemia cells that'll have it, but if you have it, that's an option for treatment. And there's an FDA-approved drug that can be effective to target those cells. We have the same thing for the For the FLT3, both gilteritinib and midostaurin can inhibit the FLT3 mutations. Ciderib was discovered that can inhibit IDH1 mutations. And then they also discovered lower toxicity chemotherapy. This drug called azacitidine, or the other one is decitabine, much better tolerated and much safer to give older people. And what they discovered is when you combine it with another drug called venetoclax, which we use commonly for a bunch of different hematologic malignancies, that can give patients who had a really poor hope with that 7+3 chemotherapy the possibility of getting a remission, and it can be very well tolerated even in older people. So that really kind of revolutionized things. So how do they design all those drugs? Well, they had to see the target, right? So a lot of science, a lot of scientists, a lot of research went into trying to understand what is making that leukemia, and why is it growing out of control and then stopping people's blood production. So there's just a cartoon, but it really describes the different cellular machinery and where things go wrong, and how they've designed drugs to block these different processes in the bone marrow. All right, so then we have the story of the CLL, leukemia. So this is probably, definitely by far the most common leukemia that we see. With the chronic leukemia like this one, it's a little hard to wrap your brain around this idea, but we don't always need to treat it. Okay, so it can grow very slowly. It's often found incidentally, and unless it's causing symptoms, or if the white cell count is very, very high, or if it's causing anemia or low platelet count thrombocytopenia, or unless it's causing big lymph nodes or large spleen, or symptoms like fevers, chills, night sweats, and weight loss and fatigue, we may just monitor. We don't always have to treat CLL. So that's kind of hard to wrap your brain around, because they find it early and treat it, right? But that's not how we do it with some of the low-grade lymphomas and the CLL. But what I did here on this slide is I showed you sort of, we talk about prognostication, right? So what's the expectation? So back in the 1970s, we had molecular targets and we didn't understand anything about genes, leukemia cells, we had no idea. So we just said, if your lymphocyte count is elevated, it's stage 0. If you have lymph node enlargement, we'll call it stage 1. If your spleen and liver enlarged, we'll call it stage 2. And if you have anemia or thrombocytopenia, I might be misquoting it a little bit, but it's the concept, then we'll call stage 3. So that's like the old rise stage. And as we got a little smarter, someone said, okay, let's check this out. So beta-2 microglobulin matters. If it's really high, that's bad. So, right, so then they included that in the prognostication. And they said, maybe if you're male or female, it makes a difference. And then how high is the absolute lymphocyte count? So they try and use other things, but that's still pretty crude. Now, once we get a little bit later on, let's go to the modern era here. We look at the patient's age, the stage based on the old days, called the clinical stage, like the rise stage. We look at how high the beta-2 microglobulin is, and that's all fine and dandy. But the biggest predictor of how patients are going to do has nothing to do with it. The biggest predictor of how patients are going to do are looking at the genes of the cells. So you can actually tell if you do this to a patient's leukemia cells years before, you can predict the behavior, biological behavior, by looking at the genes rather than looking at where they're at during that one-time slice when you're checking their lymph nodes, looking at their blood. So that patients that have a deletion 17 or a P53 mutation, those patients tend to have more aggressive disease. It doesn't tend to respond to the old-fashioned chemotherapies. And fortunately, we have better treatments now for that. But that used to be the real bad one. And then patients that have the mutated IGBH gene tend to do better than patients that have the unmutated type. So we use this panel of information then to risk stratify patients. And there's a thing called the CLL IPI, the International Prognostic Index, and we can actually categorize it to risk levels, and we can assign some statistics on there to see what might be expected. Now, in CLL, we used to use chemotherapy, just like I mentioned in the old days. We use Remdesivir, therapy, all these old drugs that we don't use too much anymore. Then immunotherapies were discovered, so Rituxan can be very effective, or nowadays we frequently won't use Rituxan so much because we use obinutuzumab for CLL, which is much more potent. Then we use combinations of newer chemotherapy drugs like FCR, which is fludarabine, cytoxin, Rituxan. So that was the standard of care for a while. That was the years during my infantry fellowship. Some new antibodies came out, and then this drug called bendamustine came out, which we really thought was going to be great. But as it turns out, nothing was better than the targeted therapies that were going to be subsequently invented. So we've left the era of chemotherapy. We've gone into the era of targeted therapies for CLL as well. So they discovered this pathway inside CLL cells called the BTK pathway, and they developed specific BTK inhibitors, which will turn off that pathway, and it puts CLL into remission. The problem is it doesn't cure it, but it can. You have to stay. Another problem is you have to stay on those pills for indefinitely, or the disease comes back. But it can control the disease for long periods of time, and patients can live pretty much normal lifestyle while they're on those drugs. There can be plenty of risks or side effects, but most patients do very well. One of the risks of a drug that you have to take indefinitely is the financial toxicity. You can actually spend your retirement savings on these drugs, which is not ideal. So that's a whole separate conversation. There's a significant financial toxicity for these expensive drugs. So in the current era, we use drugs like ibrutinib, which is the first one, or acalabrutinib, or zanubrutinib. For targeted therapies, or we use venetoclax for CLL, and often we'll combine them with obinutuzumab. So no more chemotherapy, hardly ever we give chemotherapy, but we do use all these targeted therapies. So I mentioned the antibody-based therapies, so I'll just talk for a couple of minutes on them. We had no idea. We knew that you could cure patients with certain cancers by tweaking the immune system, such as kidney cancer, melanoma. We knew that it was not common, but we knew the immune system was important. We didn't know why yet. So a lot of research went on to better understand how you could take the T cells in the body, the T lymphocytes, and have them go back in and attack cells. So we've come from an era of chemotherapy to targeted therapy, and now immunotherapy. And so it's just a schematic of some pathways that are affected in immunology. So now I was going to switch gears and talk about ALL. And actually this applies to other diseases as well. But first, bispecific T-cell engaging antibody was for an ALL. So ALL is that an acute lymphocytic leukemia? Again, commonly kids, less common in adults, but it happens. And this was a new class of drugs, so I'll explain for a minute how it works. And then they're actually trying to make these called BiTEs, bispecific T-cell engaging antibodies, BiTEs for other kinds of diseases. So now we have BiTEs for lymphoma, we have BiTEs for myeloma, and this is a super exciting class of drugs. It's what it does, on one end of the antibody here, it has specificity for an antigen on a tumor. So in ALL, it's CD19, and in lymphoma, it might be CD19. In myeloma, it will be a target called BCMA. So they can change the target, but it's going to have on one end specificity for a tumor, and on the other end, it's going to have specificity to attach to the T cells and get them all angry. And by bringing them close together with this cross-linking antibody, they're able to kill tumor cells, right? So this is another form of immunotherapy, and this is fantastic because it's actually, these are very, very potent therapies. They work oftentimes when patients run out of options. They've had every kind of chemo and immunotherapy that we have, and we'll try one of these new BiTEs out, and it can produce response rates of 60 to 70% of patients that have almost no hope. So we're hoping this will get fine-tuned in the future, but it's a very promising tool. And they are FDA-approved molecules in ALL, in lymphomas, various lymphomas, and in myeloma right now, and they'll probably be more in the future. So we could not talk about hematology cancers without talking about CAR T therapy, also very exciting. And this is another immunology type approach to attack cancer. So for certain diseases like ALL or lymphomas or myeloma, we have FDA-approved treatments, which are CAR-T treatments. What we mean by this is they take the T cells out of your body and they re-engineer those T cells to identify cancer antigens on the surface of cancer cells. And then they go in and call your immune system to destroy the tumors. And again, these can be highly effective when in patients who are highly refractory to all the other treatments that we have. And in some cases, like in lymphoma, we do think we cure our patients, but in large cell lymphoma, we may cure maybe 40 to 50% of patients with large cell lymphoma who are refractory to all the other treatments, CAR-T treatment. Not everybody, but it's pretty promising treatment. Okay, so there's just a couple more concepts. These are not treatment concepts, but these are very important concepts in hematology now that if you're interested in hematology, you need to understand. So when we do a PET scan, or let's say since we're talking about leukemia, we're going to give treatment and we're going to check a bone marrow biopsy and we're going to say, you're in complete remission. But why are you cured? Right? So the problem is we can only see what we can see. And it's a little bit like the tip of the iceberg. So this is like an upside down iceberg, I guess. But, if you were to look under the microscope, the pathologist might say you're in remission. That's that red line there. But if you look with DNA technology by other techniques like FISH, PCR, or next gen sequencing, you'll get much lower down. And you can tell, 1 in a million cells, 1 in 10 million, 1 in 100 million, 1 in a billion, right? So this tool is called MRD, minimal residual disease. We look for this now in different sorts of hematological malignancies because if you're MRD positive, tend to relapse. It's true for a lot of different blood cancers. And if you get down to an MRD negative in certain blood cancers, then those patients tend to be cured. It doesn't hold true all the time, but it's a good concept. And if you're going to be involved in learning about blood cancers, you got to understand right now about this minimal residual disease and how to detect it and what it means. Hope that's